Now I'd like to show you how to use airQ. One of the questions I get oftentimes when I'm at the shows is, how do I do it? What are my tricks? People want to know how I do it. They think somehow I know more than they do, but not really. So I'm going to show you how I do it. And I think that if people at least use my techniques, they'll be successful. They'll probably figure out other ways to do it as well, and that's okay. I'm going to use the standard inflatable airQ. This is the normal disposable airQ. This valve opens, this little holder here opens the valve up, so when you put it into the airQ, the tissue will form around the device, squeeze a little air out, and form it and make sure that it's the right size as well. So when you get done, you can just pull this off and put the little bits of air in, and I'm going to show you how to do that. Now, LMA taught a lot of people to use what they call the classic insertion technique for LMAs. Basically what they do is put their finger on the back of the cuff and they push it straight down on the hard pallet, and then it's supposed to force it around the corner. If you do that with an airQ, it's going to go like this, and that'll not be so good. I designed airQ to go on a forward angle, so instead of doing that, you put it along the base of the tongue on a forward angle toward the uvula, and you let it slide around the corner, and it slides around the corner really easily. If it doesn't just go in, I usually put my finger in behind it and just put my finger in a little scoop and scoop it around the corner. So the first thing I do when I take the airQ out of the package is put a little lubrication right there, and I run it around the corner, and I run it around the top and inside the mask bowl. And that makes everything nice and slick and makes it easier to go in. I usually hold it about like this. I usually put the head in extension. I induce most of my patients in extension anyway, so usually the head's ready to go for me. I like to rock the jaw forward or put a tongue depressor in to give me a little space. I place the airQ in on a forward angle like that. Then I either drop the tongue depressor or rotate my fingers inside the jaw, so I can do a mandibular lift as I'm sliding it in to lift the tissue up so I can slide the airway into a closed space, open space. So open, put it in on a forward angle, lift the mandible, and then I just push it down in until it stops. Now, one of the things you don't want to do with airQ is put it in too deeply. And that's said the same thing for all LMAs. If you place LMAs in too deeply, they don't work as well, and there's some dangerous things. There's some nerves down there you can damage. So it's a really good idea to not put it in too deeply. Sometimes I actually put it in, I pull it back a little, and then I just very gently nest it into place. And when I teach people to start using it, that's what I do. But once you do it a few times, then it'll be really easy. Now once it's in, you can take the red tag off and then put just a little bit of air in. The size will be just about right because as you put it in, the tissue would squeeze down on the airQ and blow air back out that valve. So I'm just going to put a little bit of air in, maybe 2 or 3 cc's at most. So about the number that's on the tube. So this is a 2.5, so I put in about 2.5 to 3 cc's. That's a really good starting point typically, but I usually stop when the inflation valve pilot balloon just starts to inflate. And once it's in, you can check ventilation like you normally would and get on with life. If you want to use the airQ as an intubation conduit, there's a few tricks that I use that I think will be helpful. So you have to take the connector off. So I rock it back and forth. I don't try to just pull it off. I actually rock it back and forth and pull it out. Now, the next thing I want to do is get an endotracheal tube ready, and then I want to do lubrication. So I put lubrication right in the tube of the airQ and make sure I take all the air out of the endotracheal tube and put some lubrication on there and run it back and forth. Now, on the top and the back of the airQ, right where my finger is, there's a couple arrows and a number, and that's how far it is to the outlet hole of the airQ. So what I'm going to do is hold the endotracheal tube at that distance in my fingers, which happens to be 16 for a 2.5. And that allows me to run this up and down gently until I get it all the way into my fingers. And now I've lubed it all the way through, but I know I haven't injured the patient, and sometimes I go really fast and twist it and get it nice and lubed. Now, once it's lubricated, I usually try one blind intubation. I do this because it's particularly successful. One of the tricks I use is I usually put the head in extension, and since I induce my patients in extension and put my airways in extension, they're usually ready to go for me. The second trick is to do what we call the burp maneuver, which stands for backward, right, upward pressure. That's a fast track maneuver, but it works really well for blind intubation with airQ. If you do those two tricks, head and extension and the burp maneuver, the intubation rate with airQ is somewhere around 80 to 90%. If you don't do the tricks, it's somewhere around 60 to 65%. So once I got it nice and lubricated, I usually put my left hand around to do the burp maneuver, and I put my little pinky finger on the cricoid ring. I hold the tube up here so I can use my index finger as a plunger to push the endotracheal tube in. So I'm just going to push it in, feel with my pinky, and most of the time it goes right into the trachea. Air the cuff up, listen to the stomach to make sure it's not in the esophagus, and then listen to the lungs and look at your end-tidal CO2 to verify placement. Now, if it goes in the esophagus and it's not intubated, then I pull it back, take the air out of the endotracheal tube, and I pull it back to that 16 number. So now I know the tip of the airQ is right at the entrance or the exit point of the airQ in the mask bowl. And I pull it back just a little bit further, and I take a endotracheal or a syringe, and I just blow the cuff up a little bit. So maybe 2 or 3 cc's at most. And that makes the balloon seal inside the airQ at about this level right here. Okay? Once I do that, then I can actually just ventilate the patient very comfortably using the airQ. Or better yet, which is my preference, is I put a bronchoscopic side port adapter on it, and then I ventilate them with the ventilator. And by doing that, I can get my hands free. So put them on the ventilator, turn your gas back on the oxygen, and you're re-oxygenating the patient, and you get your hands free while you're doing that. Send off for a flexible bronchoscope, keep the ventilator moving, pop the top off and put your scope in here, and when I do that, I usually turn the flows up to my ventilator so that I don't drop my bellows. And I put the scope in there, ventilator's still going, I'm ventilating my patient comfortably, I look it down into the trachea, and I just pass the endotracheal tube right into the trachea right over the bronchoscope. Now that's the best way to intubate, I think. So I always try one blind intubation. If it fails, I back up, I put them on the ventilator, hopefully using this side port adapter, and then I use a flexible bronchoscope to view the trachea, and I slide it over the bronchoscope. I can ventilate the patient the whole time, and if the patient's not apneic, I don't have to worry, worry about the hypoxemia. Now, once you get intubated, you have 2 choices. You can just leave it all in there, and if the case is less than, say, a half an hour, if it's a short case, I'll do exactly that. You can take the side port adapter off if you use that, pull the endotracheal tube back a little bit, and tape it all down, and you can actually ventilate through the endotracheal tube and just leave it all in there and take it out at the end. You can take the endotracheal tube out first if you'd like, and then wake them up more with the airQ, or you can just take it all at once when they wake up. It doesn't matter. I tend to just take it all out at once at the end because I like to wake my patients up. But it's up to you. If it's a longer case, I like to get it all out of there because if it's in longer, there's a lot more pressure between the endotracheal tube and the airQ, and I'm worried about that extra pressure on the larynx. So often just take it out. You can do that with the removal stylet. It's not a very clever name, but it works really well. First thing you have to do is take the connector off and put it in your pocket so you don't lose it. Hold the removal stylet down really low so you can twist it. Push it into the endotracheal tube, and then while you're pushing it in, twist it to the right and lock it in. Then once I've locked it in, I just test to make sure it's nice and stuck, and if it isn't, I just do it again. And then the first thing I do, and most people don't want to do, usually most people just want to pull it all out of there. But what I like to do is push the endotracheal tube in a little deeper till the pilot balloon is just about ready to enter the airQ tube. And then just hold it up here and pull the airQ out a little bit, which is difficult to do on a mannequin. Okay. And then straighten the tube as you go, hold it up here and just pull it out real easily. Back the endotracheal tube up a little bit, unscrew this counterclockwise, take your connector out of your pocket and put it back in, blow the cuff up, and then check your ventilation. So by putting the endotracheal tube in a little deeper at first instead of pulling it right out, it keeps you from inadvertently extubating the patient. And since the removal stylet fits nice and tightly into the endotracheal tube, you don't lose control of the endotracheal tube, so it's really easy to do. So in general, what I've shown you is the insertion technique. Leave the red tag on so you can size it up as it goes in, lube the back and the front, put it on a forward angle, lift the mandible, and slide it in gently. I've shown you my intubation techniques. Take the connector off, put the endotracheal tube in by lubing it really well together, do one blind trial, back it up, put them on the ventilator and use a flexible scope if you need to. And then at the end, you can use the removal stylet to remove the airQ and leave the endotracheal tube in safely. Now what I'd like to do is go over the features that make airQ so unique. First of all, the connector is color-coded so that it's colored for size. The sizes for airQ are half sizes, so 4.5, 3.5, 2.5. The reason I did that is because I always felt that the 5 was too big for men for the LMA, and the 4 was just a little bit bigger than most females. So I made a 3.5 that's just a little bit smaller than a 4, and a 4.5 that's just a little bit smaller than a 5, and we use those for men and women in the United States, and that works out really well. So that's where the half sizes come. I think once you get used to it, you're going to just use the color codes. So the 4.5 is purple, the 3.5 is red, and the 2.5 is yellow, as you can see. So the connectors are also translucent, so you can actually see ventilation throughout the whole airQ. And it's also removable, and it has this strap that holds it together. So if you want to intubate through it, you have to rock it back and forth and take it off, and the strap holds the connector on so you can get to the larger bore hole here. It also shortens the barrel of the airQ so you can manage the endotracheal tube a little easier. The next thing you're going to see is that the tube is not round, it's oval, and that keeps the airQ from twisting, and it's got a nice normal curve, a normal anatomic curve, so that curve allows the airQ to sit in neutral into the patient. The bowl has a very large bowl, and it has a very large concavity in it, and that allows the airQ to fit right on the end of the larynx, almost like a key, so it lines itself up really well. And this device here, people call it the epiglottis elevator or the ramp. What it does is if my finger is the epiglottis, the epiglottis will run up along the base, it go up this ramp, and it gets stuck up here. And when the epiglottis gets stuck up there, it sort of holds up the airway open for you so that you can see the glottis when you intubate, and so that it's much easier to breathe through. And this is a mechanical thing. When you mechanically hold the airway open internally, it's almost doing like a jaw lift during the case. So it allows really good breath flow for breathing, and also allows really good visualization for intubation. So it really optimizes the conduit both for breathing and for intubation. Now, the mask bowl is very anatomically shaped, so it fits in very nicely. It's a little flatter on the edge, so it doesn't roll and rock around. So it makes the airQ a really stable instrument in both ventilation and for intubation. On the top of the ramp, there's an extra hole. It's a little bit like a Murphy eye on an endotracheal tube. I call that my auxiliary hole. So even if you completely occlude the front, I can comfortably breathe through this airway, so it makes it extremely hard to occlude this airway during use. So everybody knows about the inflatable airQ. This is the one that's used most often in the field, I would guess, and this is the one that I invented first. But there's two other versions of airQ. The first one I made is the blocker airQ. This happens to be a self-pressurizing device. They come both ways, both self-pressurizing and inflatable. The reason I made the blocker is I wanted to be able to put some kind of instrument into the esophagus. And what I like to do is use either suction tubes, or specifically designed to use this tube called the blocker tube. So the reason I wanted to do this is I wanted to be able to block off and vent the esophagus, and you can't do that with the standard airQ. I also changed the bite block because I envisioned this as an emergency medicine device, so I added a lot more strength in the bite block, and it makes it extremely difficult to occlude this, and also won't break teeth. I call this part the guide tube, and that's what guides either oral gastric tubes in, or suction devices, or the blocker tube, which slides down like this. You put it in like this, and then you blow the cuff up, and you remove the stylet. Now this balloon is blown up into the esophagus. There's a multi-port vent behind it, so you can actually decompress the pressure in the esophagus while you're doing the case. Monitor this for regurgitant, and if they regurgitate, then you can pull the connector off and put an endotracheal tube through it real easily without removing the protection. The last one I invented was the SP versions in general. The problem with most laryngeal masks, one of the biggest problems is that people want to overinflate them. If you overinflate the cuff, this gets really stiff, and when it's really stiff, it presses on things, tissue. For sore throats, it also presses on nerves, which can cause respiratory issues and hoarseness. So I wanted to make an airway that was simpler and was easy to use, but also at a lower cuff volume. So what I did was I punched a hole in underneath the cuff right here, with the tube. So when you squeeze on the bag, it puffs the cuff up. And what that allows me to do is tighten the seal when I squeeze the bag and lower the pressure when I don't. So it changes the way the airway works because you don't inflate it and use constant pressure. And think about how this works. As you squeeze the bag, the pressure increases and tightens the seal. And when you let the bag down, it lowers the pressure and loosens the airway. So your pressure in the cuff is very low. I like to use spontaneous ventilation with this airway with pressure support. So my intracuff pressure, the pressure inside the cuff, vacillates between the lower level of PEEP and the amount of pressure I use for my augmentation pressure. So it may start at 4 and go up to 10, and go down to 4 and go up to 10. If you think about the mean pressure in that cuff, it's low single digits, maybe mid single digits at best. When you inflate most LMAs, even if you do it perfectly, they say at most 60, but it could be 100, it could be 150, and this is constant pressure. So I'm able to ventilate my patients with very, very low intracuff pressures, and it has an intermittent pulsatile, so it allows the tissue to reperfuse itself during the spikes. So I only really recommend this for people that do ventilation like I do. I use spontaneous triggering and with or without pressure support. It really works well with that. The seal pressure, that's the pressure that causes the leak, is a little bit lower with the airQ SP, somewhere around 18 to 20 on average, which is very comparable to the LMA Unique. But I'm able to ventilate most people very easily because I use spontaneous triggering with pressure support, and the most seal I usually necessarily need is maybe 12 to 14 centimeters. It makes it much easier, and I think it's easier on the patient, and I think it may translate to less complications.